histological surprise. Suddenly we discovered malignancy from histological report of a removed benign thyroid mass or thyroid lesion. This is called histological surprise, and later on we will discuss how to manage this histological surprise. Regarding staging of thyroid carcinoma, this staging we called it degrowth staging. Stage 1, tumor with single or multiple intrathyroid foci. Stage 2, tumor with mobile neck lymph nodes. Stage 3, tumor with fixed neck lymph nodes plus minus local invasion of surroundings. Stage 4, with this tumor with distant metastasis. About the investigations of thyroid tumor. First group of investigation is to diagnose the tumor. We use radioactive iodine 123 scan. Usually it will give by this scan called nodule. Ultrasound to visualize if it is cystic or solid. And if cystic, we should aspirate. And the criteria of malignant aspirate when it is blood stained, and if there is residual mass or rapid reaccumulation of a fluid, and when there is positive cytology for malignancy. Also, in the diagnostic procedure, biopsy. Either it is commonly used fine needle aspiration cytology, as we said, it is accurate with papillary carcinoma, or open biopsy. Take part of the thyroid gland, like isthmusectomy or lobectomy and isthmusectomy. Another group of investigation for detection of distant metastasis. For example, chest X-ray for any lung metastasis, bone scan for any bone metastasis, abdominal ultrasound to detect liver metastasis, for brain CT scan we may use. Another group of investigations are for detection of complications like laryngoscopy for recurrent laryngeal nerve invasion, bronchoscopy for tracheal invasion, esophagoscopy for esophageal invasion, and another group of investigation for detection of tumor marker. Calcitonin will be raised in medullary carcinoma, and there may be raised thyroglobulin in differentiated thyroid carcinoma. In this picture we can see there is skull mass due to follicular carcinoma. Skull mass, as we said, the follicular carcinoma commonly has hematogenous spread, and most common site is to the bone. Let us now talk about the treatment of thyroid tumor. First part of treatment is the treatment of a tumor itself. How we would treat this tumor in differentiated thyroid carcinoma, I mean papillary thyroid carcinoma and follicular thyroid carcinoma. First, by surgery. It is the main line of treatment, by total thyroidectomy with central node dissection and thyroxine replacement. And we should remember to preserve the recurrent laryngeal nerve and at least one of the parathyroid gland. Second line of treatment is by radioactive iodine, aiming at destroy remnant of normal thyroid tissue and to ablate any metastasis from the tumor. The methods of radioactive iodine. The method of using radioactive iodine: after we do total thyroidectomy, we wait till manifestation of myxedema appear. Then we do pre-therapy radio active iodine scan. We give a small dose of radioactive iodine, and we do total body scan to visualize if there is any remnant or metastasis of thyroid tumor. If there is metastasis, large ablative dose of radioactive iodine is given. And then we do post-therapy scan. This is done after the ablative dose by a few weeks. Regarding management of lymph node, as I said, the central node dissection is part of treatment of differentiated thyroid carcinoma. In children, we should do no prophylactic block dissection of lymph node. And if there is no palpable lymph node, no need for prophylactic block dissection of lymph node. If a few lymph nodes, selective picking of lymph nodes. If extensive, block dissection of lymph nodes. How we would treat histological surprise. Treatment of histological surprise. If the tumor is follicular, this depends whether it is non-invasive, so no further surgery if we already do total lobectomy. If it is invasive, we should do reoperation to remove the remnant of thyroid tissue. And papillary, if it is papillary tumor, we should do reoperation, and we have to remove the remnant of thyroid tissue with thyroid lymph node dissection. How we would treat anaplastic carcinoma, non-differentiated. Unfortunately, the majority of cases are resectable at time of presentation. So we need like palliative treatment. Tracheostomy or isthmus resection or surgical debulking for these resectable tumors, plus radiotherapy and chemotherapy for downing stage. Rarely the tumor is operable and resectable, and in this case we should do total thyroidectomy with radiation and chemotherapy. Another part of treatment of thyroid cancer is the treatment of complications. If it causes complications, like it invade the trachea, we do tracheostomy. If it invade esophagus, gastrostomy. And also another part of a treatment part is post-operative follow-up. This involves every 6 months we should do thyroid scan with the clinical examination, and we should measure tumor markers. Also, positron emission tomography, beta scan called beta scan, in follicular carcinoma treated with thyroidectomy with the post-operative rise of thyroid globulin level. We should do positron emission tomography. The purpose of these follow-up to detect local recurrence, to detect metastasis, and to detect complications. Regarding the prognosis, certain factors increase the risk, including age. Male above 40 and females above 50 years of age have bad prognosis. Size of the lesion, if tumor more than 5 centimeters in diameter, also this bad prognosis. The presence of capsular or blood vessels invasion also indicate bad prognosis. Regarding other types of tumors that affect the thyroid gland, medullary carcinoma forms about 6% of malignant neoplasm of thyroid. The tumor arises from the parafollicular cell and is therefore considered as a part of what we call apodomas tumors. These tumors that derived from neural crest, I mean it has embryological origin from neural crest, and medullary carcinoma characterized by it being it secretes calcitonin. The tumor may occur alone, that means sporadic cases, or it may be familial associated with hyperparathyroidism and pheochromocytoma, what we call it main type 2A. So the tumor either sporadic or familial, and when it is familial, it is more common in children and young adults. Microscopically, we find there is the tumor composed of sheets of neoplastic cell sets in hyaline stroma, which may contain amyloid material, and the mitotic rate of growth is usually low. Regarding the spread, it may be spread to lymph node in 50 to 60% of cases, or give rise to blood-borne metastasis. Treatment of medullary carcinoma by total thyroidectomy, removal of both thyroid glands with isthmus, and resection of lymph nodes with metastasis. Important notes that when it is a sporadic case, we should preserve all parathyroid gland during surgery, and when it is familial type, we should preserve half of one of the parathyroid gland and remove the 3 glands and a half. When it is part of main type 2, treatment of pheochromocytoma is done at first by combined alpha and beta blockers, then adrenalectomy. I mean, we should treat pheochromocytoma